Okay, so we've got a patient that we're going to be taking care of throughout the day. This is our patient. It's a 55-year-old female. She's brought into the ED by her daughter because she's not making any sense. And that's all you get. And that's commonly all you get. They just ain't right. She's got a past medical history of high blood pressure, diabetes, obesity, and unfortunately, a good portion of our patient population here will have this. She smoked for 15 years but quit 2 years ago. Here are her vital signs. Heart rate's 110, blood pressure's 88/48, respiratory rate is 24, and she's setting 92% on 2 liters. Initial thoughts? Oh, that's a great thought. That's a great thought. Anything else? How about big picture? Sick or not sick? Sick. Yeah. So this is not somebody that we're going to sit at the EMR and look through her last discharge summary or go to her last clinic note. What do? We run into the room, and where do we start? A, B, C, D, E. We're going to teach a C to start with. Now, just a forewarning, you're going to see some equations in this lecture. Please, I beg of you, I plead with you, don't zone out. Because there, as you will see, if you can just stick with me for a few minutes, you will see how ridiculously, insanely, how wonderfully simple and pragmatic these equations can be. The circulation. It's not cardiac, it's circulation. So this is our circulatory system. And yes, I did draw this myself. Our circulatory system is broken down into 2 separate circulations. We have the big picture, our hemodynamics. And then we have what happens down at the cellular level, our microcirculation. Hemodynamics is our big picture. This is our numbers. Microcirculation, this is our glimpse into what's happening at the capillary cellular level. We're going to start with the hemodynamics. The hemodynamic system is made up of 3 components, and you are going to get sick of hearing them. We're going to repeat it so many times. The tank, the pump, and the pipes. The tank refers to your venous circulation. Did you know that 70% of your blood volume is sitting in your venous circulation? When I learned about circulatory physiology, I was under the impression that we are just like a train that's just like continuously moving. I had no idea that most of the red blood cells and fluid in your body is just maxing and relaxing in the venous circulation, ready and waiting to be called on to pick up some oxygen and deliver it to the peripheral circulation, to the arterial circulation. And your hemoglobin is your oxygen-carrying capacity. Then we have the pump. And the pump is pretty self-explanatory. It's the heart, it's the lungs. And the pump, or the heart, is receiving deoxygenated blood from the venous system on the right side, sending it to the lungs where it can perform oxygenation, meaning getting oxygen to hemoglobin, and ventilation, meaning getting rid of carbon dioxide. Then it goes to the left side of the heart, where a single bolus is ejected out. Now, I had always been operating under the presumption that when the heart squeezes, this magical bolus of blood propagates the entire circulation. This couldn't be further from the truth. A cardiologist will have you believe that because they think the heart is just the greatest thing in the world. I'm certainly more partial to the arterial and venous circulation because what really happens is that the left heart squeezes and a single bolus of blood shoots out, and that bolus distends the aorta. And if you think about the arterial circulation in segments, You can think about that bolus distending the aorta, giving it elastic or potential energy, and snapping back shut, and then it goes down into the next one. And it does the same thing. It distends and it snaps shut, and then it distends and it snaps shut, and it does that all the way down to the capillary and cellular level. That's pretty fascinating, isn't it? We think about the pump as squeezing, and blood goes from the heart all the way down to the toes, and that does not happen whatsoever. Finally, we get to the pipes. The pipes receive a bolus of that oxygenated blood from the left heart, and through the coordinated sequence of distension and contraction that I just described, distribute that blood to the capillary. And the capillaries act as the conductors, where they decide who gets the blood and who doesn't. And that's based on the rate of metabolism. So we think about these capillaries as just these passive filters, but they're not. They're like the downstream conductor. So our hemodynamic system consists of the tank, the pump, and the pipes. Tank, pump, and pipes. Our hemodynamic system, the tank, the pump, and the pipes, work seamlessly together to provide organ perfusion or flow. And this is what we care about. This is what we care about, is flow, blood flow getting to the organs. But unfortunately, like so many things in medicine, we have no way to measure this. Ugh, sucks, right? We have no way of measuring flow. So instead, we must use surrogates. Get it? Surrogates? She used a surrogate? No? Not even a titter of laughter? It's a time-release joke. So what's going to happen is you're going to go out for lunch, you're going to think about this joke, and you're going to erupt in laughter. So if you see people just laughing out there, that's why. I'll know why. I think it's hilarious. So instead, we're going to use hemodynamic surrogates, pressures. But we have to remember that this is a pressure. It is not a flow. What we really care about is flow, but we can't measure flow, so we're left with pressures. I don't know if anybody's ever taught you this, but every single number that you get from a blood pressure is a surrogate for something. For instance, your diastolic blood pressure, that lower number is a surrogate for your vessel tone, or your systemic vascular resistance, as you may have heard it called. How well are your pipes clamped is reflected by your diastolic blood pressure. Your pulse pressure, which is the difference between the systolic and the diastolic. Normal being 40. 120 minus 80, 40. Normal is about 40. Your pulse pressure is a surrogate for your stroke volume, or the contractility of the left ventricle. Really low? Something's not right with the pump. Really high? Something's probably not right with the pipes. Your central venous pressure. This is the downstream pressure to venous return. This is the filling pressure of the heart. Not volume. Not volume. CVP is not a volume, but it is still a helpful, useful pressure that serves as a surrogate for the right heart. Your cardiac output is your heart rate times your stroke volume, and your organ perfusion is the difference between your mean arterial pressure and your CVP. If you don't remember any other ones, I want you to remember that organ perfusion is reflected as the difference between your mean arterial pressure and your CVP. This is why when we're in the ICU, this is the number we care about. We care about the map. We care about the map. We care about the map. I want you to care about the map. So, what do the tank, the pump, and the pipes do? They work seamlessly together to keep the map up and the CVP down. You don't want a high CVP, right? Because that reflects that there must be some degree of pump dysfunction. You want the map up and the CVP down. Got it? Tank, pump, pipes, map up, CVP down. All right. Now we're going to talk about the microcirculation, and then you're going to see how these come together. So, what this picture is attempting to illustrate, those little boxcars, that's your hemoglobin. That hemoglobin has picked up oxygen in the lungs, and it's also delivered or gotten rid of carbon dioxide. That oxygenated hemoglobin gets sent to the peripheral tissue. And when I say tissue, I mean your vital organs, all of them. It goes to the vital organs, and it gets rid of oxygen, or the tissue is extracting that oxygen. The tissue is consuming that oxygen, and that is what VO2 means. The oxygen that's getting delivered to it is the DO2, oxygen delivery. The tank, the pump, and the pipes deliver oxygen to the vital organs that consumes oxygen, and what you have left over is your oxygen extraction ratio. Does that make sense? It's pretty simple, right? And your oxygen extraction ratio is just your VO2 over your DO2, right? The amount that's consumed over the amount that's delivered. Your microcirculation is all about balancing that oxygen delivery to that oxygen consumption. When that is in imbalance, badness happens. So, what is our oxygen delivery? Oxygen delivery is your arterial oxygen content times your cardiac output. But I'm a pragmatist, and I like everything to be simple. Our oxygen content starts as our hemoglobin times the saturation of oxygen times the binding coefficient of oxygen for hemoglobin plus the PaO2 times 0.003. But let's simplify. I can't do anything about that coefficient, right? So accent. And anything in the world times 0.0, I shouldn't say anything in the world, but just about any PaO2 that we could ever achieve in the ICU times 0.003 is worthless. So get rid of that too. And you see that your oxygen delivery actually just becomes your hemoglobin and how much it's saturated. Pause for just a minute. When we recognize and realize that PaO2 is of such little consequence to the delivery of oxygen, all of a sudden we realize why we don't need ABGs anymore. I don't care what the PaO2 is, I care what the oxygen saturation is, and I can get that with just a SAT probe on the finger, the ear, the nose. Why would I poke somebody's wrist when it's excruciatingly painful when what I really care about is the hemoglobin and the oxygen saturation, not the percentage of oxygen that's dissolved in the blood? So that's our oxygen content. It's just our hemoglobin and our oxygen saturation. And then our cardiac output is our heart rate and our stroke volume. And stroke volume is determined by preload, fluid, contractility, how well the pump is squeezing, and afterload. And afterload is usually just too high in the setting of pump failure, right? Or neurologic catastrophes. So most of the time when we're thinking about oxygen delivery for a super sick patient, we're just thinking about their fluid and their contractility. So our oxygen delivery comes down to our hemoglobin, our oxygen saturation, the preload, the afterload, and the contractility. Now if you pause for just a moment and you were to think about which of those the body is naturally able to increase on its own, which ones are they? What can the body naturally compensate on its own for or with? Well, we can't naturally rapidly increase our hemoglobin, right? We can't naturally rapidly increase our oxygen saturation, though we can breathe a little bit faster, blow off a little more CO2, and try and bring in a little bit of oxygen, but that's a tremendously energy inefficient process. Can we increase our preload? A little bit. You can actually a little bit. We'll talk about this more in shock, but that venous circulation can actually clamp, specifically in the splanchnic circulation, and recruit a little bit of preload. Really what we can augment is our contractility, right? The heart can beat harder and faster. All right, that was oxygen delivery. See, it's math made simple, right? What is oxygen consumption, or VO2? This is the oxygen used by the tissue, and the normal amount of oxygen used by the tissue is about 3 to 5 mils per kg per minute. Don't ever think about that again, okay? Ignore that number. Just remember that normally only about 20 to 25% of the oxygen that's delivered is consumed. That means that normally the body is delivering 5 times more oxygen than it's using. Whoa, that's pretty incredible. I think it's pretty incredible. When that ratio of oxygen delivery to tissue consumption drops below 2 to 1, then you enter into what's called anaerobic metabolism. What are things that increase the tissue consumption of oxygen? We're going to break it down into 3 broad categories: exercise, inflammation, and increased metabolism. Now, I don't just mean exercise like somebody's doing burpees in front of you. I mean anything that mimics exercise: pain, anxiety or agitation, increased work of breathing, anything that induces inflammation in the body: infection, malignancy, connective tissue diseases. All of this will increase the consumption of oxygen and increase metabolism. Sedative withdrawal, alcohol withdrawal, benzo withdrawal, fever, hyperthyroidism. These are the 3 big things that will increase your tissue oxygen consumption. Finally, we're left with the concept of oxygen extraction ratio. And as we've said, this is just the amount of oxygen that was consumed as a ratio over the amount of oxygen that was delivered. If we say that the oxygen consumed is always about 20 to 25%, then we recognize that our oxygen extraction ratio, the VO2 over the DO2, should always be less than 30%. That was all the conceptual framework. Now we're going to make it even simpler. We can't measure VO2, and I, for one, don't want to. But what's really interesting is that your oxygen extraction ratio can be represented as the difference between your arterial oxygen saturation minus SVO2. This is your mixed venous oxygen saturation. How do you get a mixed venous oxygen saturation? You got to put in a swan. We don't put in swans anymore. How many of you, I'm curious, in medical school, have seen a swan? One hand. It's amazing. Every year that I've asked this question, the number of hands that go up dwindles and dwindles and dwindles. How many swans have you put in since you've been here? A few. I put in none. But what do we put in? Almost everybody in the ICU has one of these, don't they? They have a central line. And what can we get from the distal port of a central line? We can get a CVO2, a central venous oxygen saturation. So we can use that CVO2 as a surrogate for our SVO2. Are you ready for some math? So if our normal oxygen extraction ratio is less than 30%, we assume an oxygen saturation of 100%, we can rearrange that formula to say that our CVO2 equals 1 minus our oxygen extraction ratio, which we said should be 30% or less. So thus, we are left with a CVO2 of about 70%. 0.7 equals 70%. This is why you often hear, this is why we often say the CVO2 should be over 70%. Does it make sense now? This is where we got that. Obviously, there's a lot of assumptions in there. Normally, our CVO2 is 65 to 75%, or about 70%. If we know that that CVO2 is less than 70%, there's inadequate oxygen delivery relative to consumption. It doesn't mean that there's inadequate oxygen delivery all the time. It means that there is inadequate oxygen delivery relative to consumption. The piece of that puzzle that's missed is that oxygen consumption piece. Now, if that CVO2 drops less than 50%, we have hit our anaerobic threshold. That means that you should start seeing lactate generated. And if that CVO2 is over 85% and you've got lactate elevation, you know that there is circulatory shunting. What does circulatory shunting mean? If we go back to what we were saying about the circulation, the capillaries in particular that are acting as that conductor telling where oxygen to go, they've been taken out. They're gone. And oxygen continues to go where it's not needed, bypassing the areas that it is needed, and that's why your oxygen is so high. You've got all of this tissue saying, please help, I need oxygen. and it's not getting it. But the tissue that's like, I've got plenty of it, just continues to get more and more and more. This is a phenomenon that you will see in sepsis, and this is a phenomenon that you can also see in burn patients or house fires if they have cyanide toxicity. We're not going to go through all the details of this, but this kind of walks through how lactate's generated. Remember, you've got in the cytoplasm, you've got glucose that goes to pyruvate, and then pyruvate's got a decision to make. If oxygen's available, theoretically, it should make acetyl-CoA and go through the citric acid cycle, undergo oxidative phosphorylation, and then you've got oxygen as your terminal electron acceptor, you make carbon dioxide and energy, et cetera, and so forth. But if you don't have that, because your oxygen extraction ratio is too high, meaning your CV and your reflection of that is a central venous oxygen saturation that's too low, then you shunt to make lactate. And that is why we measure lactates. That's why you see all these lactates being checked in the ED, why you see all these lactates being checked in the ICU. I hope that you now understand why all of these lactates are being checked. Nobody ever explained it to me. I just thought that lactate equals badness. In reality, that's probably a more accurate reflection of what's going on, but it is of crucial importance that you understand why they are being checked. With all of that being said, the central venous oxygen saturation, those lactates, the reality is that this thing, your digitometer, the finger, may be the best glimpse into the microcirculation. That's why it is so important that you begin implementing capillary refill time into your physical exam, every patient, every time. It's part of the C, right? ABC, cap refill time. So this is the big picture. This is the take-home from all of circulation. As your oxygen delivery, if we start on the right, at the top, the black line that says VO2, as the oxygen delivery begins to drop, what the body will do is extract more oxygen. As the body extracts more oxygen, that is reflected by the CVO2 beginning to go down. Once that CVO2 goes down, at this gray interface over here, it hits that anaerobic threshold and the lactate begins to generate. Questions about this? Is this clear as mud? So let's summarize. Our circulation is two separate components. We've got our big picture, our 1,000-foot view, our hemodynamics. We've got our tank, our pump, and our pipes working seamlessly to maintain a high MAP and a low CVP. And at the microcirculatory level, we're trying to deliver enough oxygen relative to the oxygen that's being consumed. And our CVO2, our lactate, and our capillary refill time can provide a glimpse into our oxygen extraction ratio.